Welcome to the Deep Dive. Today, we're tackling a really important and, let's be honest, often confusing topic: navigating end-of-life care right here in Florida.
It's definitely something many families face.
Exactly. Specifically, we're going to unpack hospice, Medicare, and Medicaid. Our mission really is to clarify how these, distinct systems function and, crucially, how they connect for Florida residents making these complex decisions.
Or even if you're just curious about how it all works, it's good information to have.
Right. And for this deep dive, we're using insights from a pretty comprehensive report. It's titled AI on Florida End of Life: Hospice, Medicare, and Medicaid. Think of this as maybe a shortcut, helping you understand these crucial healthcare aspects, especially during tough times, without getting totally bogged down.
Avoiding that information overload is key.
Definitely. Okay, let's just dive in. What exactly is hospice care in Florida?
So hospice care is a very specific approach. It's really designed for people who have a terminal illness, and they've reached a point where curative treatments aren't the goal anymore. The focus shifts entirely. It becomes about comfort, about maximizing the quality of life that remains. It's really about helping people live as fully as possible in the time they have left.
So it's definitely not about giving up. I think that's a common misconception.
Not at all. It's about living.
Yeah, there's that quote in our source from Dame Cicely Saunders. It really stuck with me. You matter because of who you are. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but also to live until you die.
That captures it perfectly. And, it's important to distinguish hospice from palliative care more broadly.
Right, they sound similar.
They do overlap. Both aim to relieve suffering and improve quality of life. But palliative care can be given at any stage of a serious illness, even if you're still getting treatments to cure it.
Okay.
Hospice is a specific type of palliative care. It's for those with a limited life expectancy. Usually, the guideline is 6 months or less who've made the choice to focus on comfort, not cure.
So choosing hospice means prioritizing quality of life over, say, aggressive treatments that might extend life but reduce its quality.
Precisely. That's the core choice involved.
Got it.
Yeah.
And it sounds like it's more than just managing physical symptoms.
Oh, absolutely. Hospice uses a holistic approach.
Yep.
It's team-oriented. They address the physical pain, yes, but also the emotional, the psychosocial, even spiritual needs for both the patient and the family.
The whole person, the whole situation.
Exactly. Caring for everyone involved during a really challenging time.
Okay, that makes sense. So who in Florida is actually eligible to receive these hospice services? What are the criteria?
There are a few key things. First, physician certification is needed.
Right.
Both the patient's own doctor, if they have one, and the hospice medical director need to certify that the patient has a terminal illness and, crucially, that their life expectancy is about 6 months or less.
6 months. That's the time frame we hear often.
It is. Interestingly, the source notes that Florida statute sometimes mentions a year, but for getting Medicare or Medicaid benefits, that 6-month guideline is generally what's used. It's not exact science predicting lifespan, but it's the benchmark for benefit eligibility.
Understood. A benchmark. What else is required?
Patient election. This is critical. Hospice care is completely voluntary.
So the patient has to agree.
Yes. The patient or their legal representative, if they can't decide, must sign an election statement. It concerns they're choosing palliative care over curative treatment, and, very importantly, they can change their mind and revoke that choice at any time.
That emphasizes patient autonomy, doesn't it?
Absolutely. It's their decision.
And then there's the practical side, paying for it.
Right. Payer requirements. So eligibility for coverage is usually tied to having Medicare Part A or being enrolled in Florida Medicaid or sometimes private insurance.
Okay. And is it only for certain diseases like cancer?
Not at all. That's another common misconception. While cancer is frequent, hospice is for any terminal illness meeting that prognosis. So advanced heart disease, lung disease, kidney or liver failure, dementia, including Alzheimer's, neurological conditions like ALS, stroke complications, severe infections.
Wow, quite a range.
It is. And indicators might be things like frequent hospital visits, losing weight without trying, needing more help with daily activities, worsening pain. Those can signal eligibility.
So it's based on the overall condition, not just one diagnosis. And what if someone lives longer than 6 months? Can they stay in hospice?
Yes, absolutely. The 6 months isn't a hard limit on receiving care. Hospice care is structured in benefit periods. There are 2 initial 90-day periods, followed by unlimited 60-day periods.
Okay.
To continue, a hospice physician just needs to recertify at the beginning of each new period that the patient still meets the criteria. It acknowledges that prognosis isn't exact.
That seems fair. And are there specific things Florida law requires hospices to do?
Yes. Florida statute mandates that hospices ask patients about advanced directives, things like a living will or a healthcare surrogate designation.
Important documents.
Very. And they also have to inform patients about their rights under Florida law. It's all about respecting patient wishes and ensuring they know their options.
Okay, so we know what hospice is, who qualifies. Now, what services are actually provided in Florida? What does that look like?
It's delivered by what's called an interdisciplinary team, or IDT.
IDT, got it.
Yeah. And this team brings together a whole range of specialists. You'll typically have a hospice physician, nurses, RNs, and LPNs, medical social workers, chaplains or spiritual counselors, certified hospice aides, trained volunteers.
Volunteers, too?
Yes, volunteers play a significant role. Also, therapists if needed for palliative goals, dietary counselors, bereavement counselors, and importantly, the patient's own personal physician is often involved too.
That's a very comprehensive team, everyone working together.
That's the goal, addressing all the different needs.
And Florida has specific rules about this team.
It does. The statute sets a minimum team composition needing a physician, nurse, social worker, and counselor. It also requires hospices to use trained volunteers for at least 5% of their total paid staff hours. That covers both patient care and administrative support.
Interesting, that 5% volunteer requirement, it emphasizes the community connection.
It really does.
So what are the core services the IDT delivers?
Well, Florida law mandates certain core services must be provided directly by the hospice employees. That includes nursing, social work, pastoral or counseling services, dietary counseling, and bereavement counseling.
Okay.
Physician services can be direct or contracted. The hospice is responsible for making sure all necessary care is available 204/7.
247 availability is crucial. What are the key components patients and families can expect?
Pain and symptom management is number one, keeping the patient comfortable using medications and other methods. They also provide necessary medical equipment. Think hospital beds, wheelchairs, oxygen, and supplies.
What about medication?
Medications related to the terminal illness, specifically for managing pain and symptoms, are covered. Then you have personal care from hospice aides, help with bathing, dressing, things like that, plus companionship, and they report changes back to the nurse.
That aid role sounds vital.
It is. And then there's emotional and spiritual support. Counseling, respecting beliefs. Florida law is clear they can't impose their values. And very importantly, caregiver support.
Ah, yes, the family caregivers need help too.
Immensely. So education, emotional support, and respite care, giving the caregiver a needed break. This is huge since so much hospice care happens at home. And finally, bereavement care for the surviving family for at least a year after death. That's mandated in Florida too.
A full year of bereavement support, that's significant. It really shows the focus isn't just on the patient's final moments, but the whole family's journey.
Exactly. It acknowledges the wider impact.
Now, are there different intensities or levels of hospice care?
Yes, there are 4 official levels. The most common is routine home care, or RHC. That's intermittent visits from the team wherever the patient lives.
Okay, standard visits.
Then there's continuous home care, CAC. This is more intensive nursing care provided right in the home during a medical crisis. Has to be at least 8 hours within a 24-hour period.
For those really tough times.
Right. Third is general inpatient care, GIP. This is for short stays in a facility like a hospice unit or hospital when pain or symptoms just can't be managed at home.
Okay, short-term, facility-based for symptom crises.
And fourth is inpatient respite care. This also involves a short stay in a facility, up to 5 days usually, but its purpose is to give the family caregiver relief a break.
So GIP for symptoms, respite for the caregiver. Got it. These levels provide flexibility then.
Exactly. While home is the focus, these levels adapt to changing needs.
That flexibility is good. So where does all this care actually happen in Florida? You mentioned home is primary.
That's right. Hospice isn't really a place, it's a philosophy of care. The patient's own home is the preferred and most frequent setting. Florida law really emphasizes supporting people at home. The team makes regular visits, and they're on call 24/7.
But what if someone's already in, say, a nursing home or an assisted living facility?
Hospice services can absolutely be provided there. The hospice team comes into the nursing facility, or ALF, and coordinates care with the facility staff. It's an extra layer of specialized support. Florida law explicitly allows this.
So you can get hospice care wherever you call home, essentially.
Pretty much, yes.
And what about those dedicated hospice inpatient facilities or units?
Those are used for the general inpatient care or respite care levels we talked about. They could be freestanding buildings or units within hospitals or nursing homes.
Okay.
Florida has rules for these places they need to ensure privacy, dignity, feel somewhat home-like. There are often limits on how many people share a room, and there's a capped GIP, and respite days combined can't be more than 20% of a hospice's total patient care days in a year.
So inpatient care is important, but it's capped to keep the focus on community care.
That seems to be the intent, yes. The vast majority happens outside those facilities.
And some regular hospitals might have hospice programs too.
Yes, some hospitals have dedicated hospice units or specialized teams that work within the hospital setting, useful for complex symptom management needing round-the-clock hospital resources.
Good to know there are various options. Now, our source mentioned something really interesting, that Florida law requires hospices to serve all terminally ill people, regardless of their ability to pay. That sounds noble, but challenging.
It is definitely both. It's a crucial principle, ensuring access. But yes, it creates financial challenges, especially for nonprofit hospices. While Medicare and Medicaid cover many, this mandate means providers sometimes care for people with insufficient or no coverage.
How do they manage that?
They often rely heavily on community donations and fundraising to bridge that gap. It really underscores how vital community support is to make this compassionate care available to everyone who needs it, finance aside.
Absolutely. Okay, so hospice offers this incredible support system. Let's shift gears a bit and talk about how it's usually paid for, starting with the big federal program, Medicare. Can you give us the basic rundown of Medicare in Florida?
Sure. Medicare is the federal health insurance program.
Right.
It's primarily for folks 65 and older.
Right.
But it also covers younger people with long-term disabilities, or those with end-stage renal disease kidney failure requiring dialysis or transplant or ALS. It's managed federally by CMS, the Centers for Medicare and Medicaid Services, and enrollment is usually handled through Social Security.
It's like a foundational healthcare program for seniors and certain others, and has different parts, right? It's not just one thing.
Correct. There are four main parts, A, B, C, and D. Part A is often called hospital insurance.
Okay. A for hospital stays.
Mostly, yes.
Oh.
It covers inpatient hospital care, limited stays in a skilled nursing facility after a hospital stay, hospice care that's key for our discussion, and some home health services.
And do people pay for Part A?
Most people don't pay a monthly premium for Part A if they or their spouse paid Medicare taxes while working for long enough, usually about 10 years. But there are costs, like deductibles for hospital stays and coinsurance after a certain number of days.
Okay, that's Part A. What about B?
Part B is medical insurance. This covers outpatient services. Think doctor visits, outpatient procedures, preventive care like screenings, lab tests, medical equipment DME, durable medical equipment, mental health services, physical therapy, a wide range.
So outpatient stuff, and this one usually has a premium.
Yes, Part B requires a monthly premium for most people. The amount can vary, and it's often higher for people with higher incomes. There's also an annual deductible, and then you typically pay 20% coinsurance for most services covered by Part B.
And it's optional.
Technically, yes, but it's highly recommended. If you don't sign up when you're first eligible and don't have other similar coverage, like from an employer, you could face a penalty on your premium for life.
Good to know. Okay, A is hospital inpatient, B is Medi-Cal outpatient. What's Part C?
Part C is Medicare Advantage. These are private insurance plans like HMOs or PPOs that contract with Medicare.
Ah, the private plans you see advertised.
Exactly. To join one, you must have both Part A and Part B. These plans provide all your Part A and Part B benefits. They must cover everything original Medicare covers, except usually hospice care that's still paid for by original Medicare Part A, even if you're in an Advantage plan.
That's an important detail about hospice.
It is. Advantage plans often have different rules, different costs, provider networks you have to use. Many also bundle in Part D prescription drug coverage, and they might offer extra benefits not covered by original Medicare, like some dental, vision, or hearing services.
So it's a trade-off. Maybe lower costs, but less provider choice.
That's often the trade-off, yes.
Yeah.
Convenience and potential extra benefits versus the flexibility of choosing any doctor who accepts Medicare with original Medicare.
Makes sense. And finally, Part D.
Part D is all about prescription drug coverage. It helps pay for your outpatient medications. These are also offered through private plans approved by Medicare. You can get a standalone Part D plan to go with original Medicare, or, as I mentioned, drug coverage is often included in Medicare Advantage plans.
Right.
Those are called MAPD plans.
Right.
Part D plans have their own premiums, deductibles, and cost-sharing structures, often using tiers for different drugs. And like Part B, if you don't enroll when first eligible and lack other drug coverage, you might face a late enrollment penalty.
There's a change coming for Part D costs.
Yes, a significant one. Starting in 2025, there will be a $2,000 annual cap on out-of-pocket costs for medications covered under Part D. That could be a big help for people with high drug expenses.
That is a big deal.
Yeah.
So eligibility for Medicare, it's mostly age 65, or disability, ESRD, ALS. Is enrollment automatic?
Often, yes. If you're already getting Social Security or railroad retirement benefits when you turn 65, you'll typically be enrolled automatically in Part A and Part B.
Okay.
But if not, you need to actively sign up through Social Security, usually during specific enrollment periods.
Right. And what are some examples of things Medicare covers, besides hospice, just to give a sense of the scope?
Sure. Part A, beyond inpatient hospital and some S&F care, includes some home health. Part B covers a lot. Doctor visits, primary care and specialists, outpatient surgery like getting cataracts removed, ER visits, preventive screenings, mammograms, colonoscopies, diabetes checks, durable medical equipment like walkers, wheelchairs, oxygen.
That's a lot already.
Mental health therapy, physical and occupational therapy, ambulance services when medically necessary, certain vaccines like the flu shot, limited chiropractic care, and telehealth visits too, though the rules around telehealth might evolve post-2024.
It's pretty comprehensive for medical needs, but it doesn't cover everything, right? What are some key things Medicare usually doesn't pay for?
That's really important to understand. Original Medicare generally does not cover long-term custodial care. That's help with daily activities like bathing, dressing, eating over a long period.
So nursing home stays just for assistance, not skilled care.
Exactly. Also, most routine dental care cleanings, fillings, dentures isn't covered, nor are routine eye exams for glasses or hearing aids and the exams for them. Cosmetic surgery is out usually, massage therapy, routine foot care. Those are typically not covered either.
Good to know those gaps, although you mentioned some Medicare Advantage Part C plans might cover some of those extras.
Correct. Some Part C plans do offer benefits for dental, vision, or hearing, so that's something people weigh when choosing between original Medicare and Medicare Advantage.
Okay, that gives us a solid picture of Medicare. Now let's switch over to the state-level program, Florida Medicaid. What's its main goal?
Florida Medicaid is a joint federal and state program. Its fundamental purpose is to provide health coverage to eligible low-income individuals and families in Florida.
It's a safety net.
It really is. It covers groups like children, pregnant women, parents with low incomes, seniors, and people with disabilities who meet the eligibility criteria.
And who runs it here in Florida? Is it one agency?
It's mainly two state agencies working together. The Agency for Healthcare Administration, or AHCA, is the main administrator. They handle the budget, set policies, oversee the facilities and providers, and manage the managed care system.
AHCA manages the program overall.
Right. Then, the Department of Children and Families, DCF, is primarily responsible for determining eligibility for most people. They process applications, verify income and assets, etc., often through their Access Florida system.
Okay, AHCA runs it, DCF checks eligibility. Got it.
And just a side note, for people getting supplemental security income, SSI, the Social Security Administration actually determines their Medicaid eligibility.
Ah, interesting link there. You mentioned managed care. Is that how most Medicaid services are delivered in Florida?
Yes, the vast majority of recipients get their services through the statewide Medicaid Managed Care Program, SMMC. Right. People enroll in a private health plan that has a contract with the state. That plan then coordinates their care through its network of providers. There are three main parts to SMMC: managed medical assistance, MMA for regular medical services, long-term care, LTC, for nursing home or home community-based care, and separate dental plans.
So you pick a plan within the SMMC program. Okay, who is actually eligible for Florida Medicaid? What does it take?
Well, there are non-financial requirements first. You have to be a Florida resident and either a U.S. citizen or a qualified non-citizen.
Okay, residency and citizenship status.
Then you generally need to fit into one of the specific eligibility categories, like being a child or pregnant, or a parent caretaker relative with a very low income, or age 65 or older, or blind or disabled, or a former foster youth, or someone needing long-term care services.
So you have to fit a category. And then the big one, financial eligibility. Income and assets.
Exactly. And this is where it gets quite strict and complex. The income limits vary significantly depending on the group you fall into.
How strict are we talking?
For many groups like children and pregnant women, they use what's called Modified Adjusted Gross Income, or MEI. The limits are higher for them. But for parents, the limit is often very, very low. For the aged, blind, and disabled ABD categories, including those needing long-term care, they use different rules, non-ABI rules. For 2025, the example limit for an individual in these categories is projected around $2,901 per month.
$2,901 a month. Still sounds specific. What if someone's income is slightly over that for long-term care?
That's where something called a Qualified Income Trust, or QIT, can sometimes help. It's a legal tool, sometimes called a Miller Trust, that allows someone whose income is over the limit to still qualify for LTC Medicaid by putting the excess income into this special trust. It has very specific rules for how the money can be used.
Okay, a potential workaround for income. What about assets?
Asset limits are also very strict. For most ABD and LTC programs, the limit for an individual is typically $2,000. For a married couple both applying, it's often $3,000.
Wow, $2,000 is not much.
It's not. There are rules to protect some assets for the spouse who isn't applying for long-term care, the community spouse. In 2025, that protected amount is projected to be up to $157,920. But the applicant themselves still has to meet that low limit.
What counts as an asset? Like cash in the bank?
Yes, things like cash, bank accounts, checking, savings, stocks, bonds, and real estate, other than your primary home, generally count.
And what's exempt? What doesn't count towards that $2,000?
Usually your primary residence is exempt, although there can be an equity limit if a spouse or dependent child doesn't live there. One vehicle is typically exempt, personal belongings, household goods, prepaid funeral plans up to a certain limit, and sometimes retirement accounts like IRAs or 401ks, if they're in payout status, might be exempt.
Okay, so some key exemptions. It sounds like applying for long-term care Medicaid is particularly complex.
It really is. Besides the income and asset rules, there's the 5-year look-back period.
The look back. What's that?
Medicaid looks back 5 years from the date you apply for long-term care to see if you transferred any assets, like giving money or property away to family, for less than fair market value.
To try and qualify.
Exactly. If they find transfers like that, it can result in a penalty period where Medicaid won't pay for your long-term care services, even if you're otherwise eligible.
That's a major hurdle, potentially.
It can be. And for long-term care, whether in a nursing home or the home-based waiver program, you also have to meet a medical necessity requirement. You need to be assessed, usually by a unit called CARES, and found to need a nursing facility level of care, or an FLOC.
So, financial eligibility and medical need.
Both. There's also something called the Medically Needy Program. It's a spend-down option for people whose income or assets are a bit too high, but they have very high medical bills. They can potentially qualify by spending down their excess income on medical expenses each month.
It sounds like navigating Medicaid eligibility, especially for long-term care, can be really challenging.
It absolutely can be. It often requires careful planning, sometimes well in advance.
Okay, so assuming someone qualifies, what key services does Florida Medicaid cover? Especially thinking about long-term care needs.
Well, it covers the core medical services, doctor visits, hospital care, inpatient and outpatient, labs, x-rays, family planning, transportation to medical appointments, NEMP.
Basic medical needs.
Right. And for children under 21, it's very comprehensive under the EPSTT program. Early and periodic screening, diagnostic, and treatment. That includes regular checkups, vision, hearing, dental, and any medically necessary treatment.
What about things like prescriptions, dental, vision for adults?
Prescription drugs are generally covered, though plans have formularies, lists of preferred drugs. Dental and vision for adults are typically more limited than for kids, often focused on emergency care or specific problems, not routine preventative care.
Therapies, like physical therapy.
Yes, therapies, physical, occupational, speech are covered when medically necessary. Mental and behavioral health services are covered too, as is durable medical equipment. And importantly for our topic, Medicaid covers hospice services, much like Medicare does.
Okay, and the big one, long-term care services.
Yes. Medicaid covers care in a certified nursing facility for those who meet the financial and medical eligibility criteria. That includes room, board, nursing care, therapies, personal care.
So nursing home costs covered. What about staying at home?
That's where the home and community-based services, HCBS, come in, delivered through that SMMC LTC waiver program we mentioned.
The waiver, right?
This is for people who qualify for a nursing facility level of care, but prefer to live in the community at home or sometimes in an assisted living facility.
What kinds of services does the waiver provide?
It's a package tailored to the person's needs. Can include case management, personal care assistance, homemaker services, adult day health care, respite for caregivers, specialized medical equipment, personal emergency response systems, PRS, and some home modifications. It can also cover services provided in an ALF, but generally not the room and board costs there.
Ah, that's a key distinction for ALF services, not rent.
Correct. There might be a very small state supplement, optional state supplementation, OSS, for very low-income individuals in ALFs, but it doesn't cover the full room and board typically.
And you mentioned a wait list for this waiver.
Yes, that's a critical point. Unlike nursing home Medicaid, which is more like an entitlement if you qualify, the number of waiver slots is limited by state funding. So people applying from the community often go onto a wait list managed by the Department of Elder Affairs. Priority is based on need, assessed by the local Aging and Disability Resource Center, ADRC. That wait can be long.
But there was that bypass.
Sort of. The source notes that if someone is in a nursing facility for at least 60 consecutive days and meets Medicaid criteria, they often get priority for waiver enrollment when they're ready to discharge back to the community. It's a pathway some use, but it means spending time in a nursing home first.
That's quite a system. There's also PACE.
Yes, the program of all-inclusive care for the elderly. It's available in some areas. It integrates Medicare and Medicaid funding for people 55 plus TRIMACs who need a nursing facility level of care, but can live safely in the community with PACE support. It provides comprehensive medical and social services.
Okay, that's a lot to digest on Medicaid. So we've got hospice, Medicare, Medicaid laid out. Now let's bring it back together. How does hospice coverage specifically work with Medicare and Medicaid in Florida? They're the main payers, right?
They absolutely are. For most people eligible for Medicare, the Medicare hospice benefit, which falls under Part A, is the primary source of coverage.
And what does that Medicare benefit cover again?
It's pretty comprehensive for the terminal illness. Covers the services of the interdisciplinary team, medications for pain and symptom management, durable medical equipment, medical supplies, short-term inpatient care for symptoms or respite, counseling, grief support.
Sounds like most of the core hospice services. What does the patient pay?
Usually very little. There might be a small copay for outpatient drugs, maybe up to $5 per prescription, and a small coinsurance, about 5%, for inpatient respite care stays. They do need to keep paying their Part B premium, and Part A premium if they have one.
What's not covered by the Medicare hospice benefit?
Crucially, it doesn't cover treatments intended to cure the terminal illness. It also doesn't cover drugs or services unrelated to the terminal condition. You'd use your regular Medicare Part B or D for those. And big one, it generally doesn't cover room and board costs if you're living at home, in an assisted living facility, or even in a nursing home, except during those short GIP or respite stays.
So Medicare pays for the care, but not the rent or facility costs long term.
That's the general rule for Medicare's hospice benefit. If you need care for a condition unrelated to your terminal illness while on hospice, your regular Medicare benefits can still be used. The hospice team helps coordinate what's related versus unrelated.
Okay, that's Medicare. How does Florida Medicaid cover hospice?
Florida Medicaid also have a hospice benefit, and its scope largely mirrors Medicare's in terms of the types of services covered: nursing, physician, aid, counseling, meds, equipment.
Similar services, eligibility rules too.
Pretty similar. You need that physician certification of 6 months or less prognosis, and the patient has to elect the hospice benefit, choosing palliative over curative care.
Any key differences with Medicaid?
A couple of important ones. For children under 21, Medicaid in Florida allows something called concurrent care. They can receive both hospice services and continue curative treatments at the same time.
Oh, that's different for kids.
It is. And the other major difference relates to room and board in nursing facilities.
This is where Medicaid might help where Medicare doesn't.
Exactly. If a Medicaid recipient is eligible for Medicaid nursing home coverage and resides in a Medicaid-certified nursing facility while receiving hospice, Florida Medicaid will cover the cost of room and board there.
How does that work technically?
Medicaid reimburses the hospice for the room and board at about 95% of the facility's usual Medicaid rate, and then the hospice pays the nursing facility.
So for a Medicaid-eligible person in a nursing home, Medicaid covers the stay even while they get hospice care. That's huge.
It's a critical piece of coverage for that population. However, this generally does not apply to assisted living facilities, ALFs. Medicaid typically won't pay for room and board in an ALF, even if the resident is receiving hospice services there.
So there's a gap for ALF residents needing hospice compared to nursing home residents, financially speaking, under Medicaid.
Yes, unless they have other means to pay the ALF's room and board costs. The LTC waiver might cover services in the ALF, but not the rent itself.
What about people who have both Medicare and Medicaid? Dual eligibles. How does hospice work for them?
For dual eligibles, it's usually a coordinated effort. Medicare acts as the primary payer for the core hospice services under Part A.
Okay, Medicare pays first.
Then Medicaid acts as the secondary payer. Critically, as we just discussed, Florida Medicaid can cover that nursing facility room and board cost for dual eligibles receiving hospice in that setting. Medicaid might also cover some of Medicare's cost sharing, like those small copays or coinsurance, for certain dual eligibles, like QMB's qualified Medicare beneficiaries.
So being dually eligible offers the most seamless coverage, especially if nursing home care is needed with hospice.
Generally, yes. It provides the most comprehensive package, covering both the hospice care via Medicare and the long-term stay via Medicaid. The main challenge, of course, is meeting Medicaid's strict financial eligibility rules to become dually eligible in the first place.
Right, and you mentioned coordination being key.
Absolutely essential. For anyone on hospice using Medicare or Medicaid, the hospice team must be involved in arranging or providing all care related to the terminal illness. If a patient goes to the ER or hospital for the terminal condition without the hospice arranging it, Medicare or Medicaid likely won't pay for that visit.
So call the hospice first, always.
That's the rule of thumb. Communication and coordination with the hospice team are paramount to ensure coverage works smoothly.
Okay, that clarifies how the coverage intertwines. Now let's talk about actually getting these benefits. How easy is it to enroll in Medicare in Florida? What's the process?
Medicare enrollment is usually pretty straightforward, relatively speaking. As we said, if you're getting Social Security or railroad retirement benefits, enrollment in Part A and B is often automatic around age 65 or after 24 months of disability.
Automatic is easy. What if it's not automatic?
You need to actively enroll through the Social Security Administration, SSA. The easiest way is usually online at the SSA website, ssa.gov. You could also call them or visit a local office.
Online sounds convenient.
It is. The most important thing is hitting the right enrollment window. There's the initial enrollment period, IEP, which is the 7 months around your 65th birthday. There's a general enrollment period, GEP, early each year if you miss your IEP. But enrolling late can mean penalties, especially for Part B. And then there are special enrollment periods, SEPs, if you lose other coverage, like from work.
So timing is critical to avoid penalties.
Very critical for Part B and sometimes Part A if you have to pay a premium. But overall, the process itself applying is generally not overly burdensome once you know when to do it. Finding doctors who accept Medicare is also usually not too difficult. It's based on entitlement age or disability, not financial need.
Okay, Medicare. Relatively straightforward access, watch the deadlines. How does that compare to applying for Florida Medicaid?
Applying for Florida Medicaid, well, it's generally a more involved process. It's handled at the state level by DCF.
More complex, you think?
Definitely. The main way to apply is online through the ACESS Florida portal. That's usually the quickest. But paper applications are also an option. Applying itself is free.
What makes it complex?
The documentation requirements. You need to provide extensive proof of pretty much everything. Identity, citizenship or immigration status, Florida residency, Social Security number, all sources of income, all assets.
All assets.
Yes. And for long-term care, remember that 5-year look back on asset transfers. You might need bank statements going back 60 months. You also need proof of certain expenses, other insurance you might have, proof of disability if that's the basis for applying. It's the applicant's responsibility to provide all this information by the deadlines DCF gives.
That sounds like a lot of paperwork gathering.
It can be. After you apply, DCF reviews everything. They might schedule an interview. They'll likely send notices requesting more verification documents. You can track the status online.
How long does it usually take?
Federal rules say decisions should generally be made within 45 days or 90 days if eligibility is based on a disability. Simpler cases, like for kids based on MGI income, might be faster. But complex applications, especially for long-term care or if information is missing, can definitely take longer.
And then there's that extra layer for the long-term care waiver access.
Right. Even after you're found financially and medically eligible for LTC Medicaid, getting onto the waiver for home and community-based services involves another step. You start with a screening by the local ADRC, which gives you a priority score. Then you go on that statewide waitlist managed by DOEA. Getting off the waitlist and actually enrolling in an LTC managed care plan to start receiving waiver services can take it can take a long time depending on your priority score and funding availability, unless you use that 60-day nursing home stay pathway.
Wow. So comparing the two, Medicare seems much more direct if you meet the age disability criteria.
Generally, yes. Medicare's strengths are often automatic enrollment, standardized federal rules, usually less documentation upfront for basic enrollment, and an efficient online system. The main challenge is understanding the parts and hitting the enrollment periods.
Whereas Medicaid.
Medicaid is more challenging and variable. Its strength is providing that crucial coverage, especially for long-term care for those who qualify. The online portal helps, but the challenges are significant. Strict financial rules, the heavy documentation burden, potential delays, the LTC waiver waitlist, complexities of managed care, and needing annual redeterminations to keep coverage.
It really boils down to that fundamental difference, doesn't it? Medicare as an entitlement versus Medicaid as a means-tested program.
Exactly. That difference shapes the entire access experience for you, the applicant. Medicare is about being eligible, age disability. Medicaid is about proving eligibility, financial need category.
Okay, understanding that access difference is key. So let's try to synthesize this. For someone in Florida facing these end-of-life decisions, how do they figure out the better path or how these systems work together for them?
Like we've said, there's no single best option overall. It hinges entirely on your specific health situation, your financial resources, and your eligibility for these programs.
Let's recap the access ease comparison again briefly.
Sure. Medicare, generally easier and more predictable to access if you meet the age or disability criteria. Medicaid, significantly more complex due to the strict financial tests, heavy documentation, and potential wait lists, especially for that LTC waiver.
And how does accessing hospice itself fit into this?
Remember, the medical eligibility for hospice, the terminal diagnosis and prognosis is separate. Getting the service is usually pretty smooth if you already have Medicare Part A or Florida Medicaid coverage. The access challenge isn't typically getting the hospice team once you're covered. It's often about accessing coverage for the room and board costs in a facility like a nursing home. And that often requires navigating the more difficult Medicaid long-term care application process unless you have private funds.
Okay, so the bottleneck isn't usually the hospice service itself, but the underlying payment source, especially for long-term facility stays.
Precisely.
So determining what's better really means aligning the options with your circumstances.
Exactly. If you're Medicare eligible, maybe retired with some savings but not low income enough for Medicaid, Medicare is your primary route. It's easier to access for the core hospice medical services. But you'd need to plan separately for potential facility room and board costs if that becomes necessary.
Okay. And if you are low income and meet the criteria for Medicaid,
then Medicaid offers that broader safety net, crucially including the long-term nursing home coverage that pairs well with hospice in that setting. But the hurdle is getting through the Medicaid application process itself.
and for the dual eligibles.
They really have the most comprehensive setup, particularly for hospice in a nursing facility, because Medicare covers the care and Medicaid covers the room and board. Again, the challenge is meeting the criteria to become dually eligible.
So when thinking specifically about hospice needs,
Accessing the hospice services is relatively efficient once you have Medicare or Medicaid. Accessing comprehensive financial support, especially including room and board, is where Medicaid, often paired with Medicare for duals, is better in terms of coverage scope, but it's much harder to qualify for and access initially. Medicare is easier for the services part, but leaves that room and board gap.
it really requires a careful, honest assessment of your health, finances, and what programs you might already qualify for.
That's the only way to determine the better pathway for your unique situation.
This has been incredibly illuminating. Thank you for walking us through all that complexity. So just to quickly recap the main takeaways for everyone listening.
Sure, hospice care focuses on comfort and quality of life when facing a terminal illness.
Right. Medicare is the federal program providing health insurance, primarily for those 65 plus or with disabilities, and it includes a solid hospice benefit covering the medical aspects of that care.
And Florida Medicaid serves as that vital safety net for eligible low-income individuals and families. It also covers hospice, and critically, for those who qualify, it can cover long-term nursing home room and board, which is essential for many receiving hospice in that setting, especially dual eligibles.
And we've certainly established that navigating these systems, figuring out eligibility, understanding coverage gaps, it can be complex. The right path truly is unique to each person's circumstances.
Absolutely. It's very personal.
So for you, our listener, we really hope this deep dive has given you a clearer picture, empowered you with understanding to help make informed decisions, whether for yourself or someone you care about.
And if you need more specific guidance, remember there are resources out there. State agencies like AHCA, DCF, your local ADRC. The SHINE program in Florida is fantastic for free, unbiased Medicare counseling.
And for really complex situations, especially around Medicaid planning for long-term care.
Consulting with a qualified elder law attorney who specializes in Florida Medicaid can be a very worthwhile investment.
Definitely good advice. And finally, as we wrap up, maybe a thought to leave you with. Given everything we've discussed today, all the rules, the potential gaps, the complexities, what do you think are the broader societal implications for ensuring truly dignified and accessible end-of-life care for all Floridians?
That's a deep question, something worth reflecting on.
Indeed. Thanks for joining us for this deep dive.
This is DigitView.